All right, welcome to the liver part of the lecture series. I'm not sure if you are already in intestinal or if you are in pancreas. I suggest you do the intestinals together, gastric and intestinals, and then doing the liver first and then the pancreas. Again, and the slide that might be uploaded for you says liver disease and pancreatitis. This just one PowerPoint is liver disease, and then we have another PowerPoint about pancreas and gallbladder. I think liver is the bigger overarching organ, so I'd like for you to tackle that one first. And I think I said that at the beginning of the pancreas lecture as well. Because they all go together, basically. Let's talk about the liver, though, and all the amazing things it does, just like the kidney. Very underrated organ, very, very important, has a lot of jobs. So the kidney had 6 jobs. I've kind of knocked this down to 3 jobs, just so that it's easier to remember a little bit. And then when I do our cues, our signs and symptoms, I kind of have those organized by job as well. So the liver itself is a production, storage, and waste management facility. So it doesn't just handle waste, it does a lot of productions as well. Our healthy liver produces clotting factors. It's the only source of clotting factors. So for our clotting cascade, very important to have a functioning liver. It also stimulates the production of platelets. You know how we have erythropoietin to stimulate red blood cells that comes from the kidney. We have thrombopoietin, which stimulates the productions of platelets. Platelets and red blood cells are actually made in the bone marrow, but the organs that stimulate their production are the liver and the kidney. The kidney stimulates red blood cells in the marrow, and the liver stimulates platelets in the marrow. So we can see that losing our liver is going to affect our clotting, because if clotting factors and the stimulation for platelets comes from the liver, then we're going to have problems with clotting if our liver is not producing these products. So it also produces albumin, which is the main protein in plasma. So we talked a little bit about albumin when you have glomerulonephritis or nephrotic or syndrome. We lose our albumin. Well, it's produced by the liver. And so when we lose it, we're just basically losing it faster than we can produce it. But the liver will make more, because the liver is the production facility for albumin, clotting factors, and bile. Bile is produced in the liver. The bile's purpose, it has 2 jobs. The bile that is produced in the liver is supposed to carry bilirubin. So the liver is involved in breaking down all these red blood cells because it's part of our waste management facility. But bilirubin is a waste product, and so it's supposed to latch onto the bile and get carried down into the intestine with the bile. Bile, when it hits the intestine, also helps break down fats. So bile is a very, very useful tool, but it is made in the liver. It's made in the liver and then stored in the gallbladder, but it is made in the liver. It's produced in the liver. And the reason it produces it is so that it can bind up with the bilirubin there, and then it goes and kind of hangs out in the gallbladder. And then when it's used, it's get pulled to the intestine. And then eventually that bilirubin will be sent out in the stool. Bilirubin is actually what makes our stool brown. So bilirubin is, like I said, a breakdown component of red blood cells. It's a waste. It's supposed to be removed, and what removes it is bile. So bile picks up the bilirubin, carries it with it, and takes it to the intestine. But bile also can help break down fats in the intestine. It's a digestive enzyme. The liver also makes cholesterol and triglycerides. So we got a lot of stuff going on in the liver there. It's also a storage facility for vitamins, minerals that we might need to store for later on. It also helps us deal with extra glucose. It converts that to glycogen, and then the liver is also responsible for breaking down that glycogen to give glucose to the body when it needs it. So it is a storage facility for some extra. You thought it all went to your fat, but actually the liver stores some of it too before it gets stored out in your fat. So anyway, that's the storage facility jobs. And the waste management facility is a cleaning and recycling facility. The biggest one that we know about is detoxifying drugs. So that's a great job. Most drugs are detoxified, broken apart in the liver, and then sent to wherever it needs to go to be excreted. It converts ammonia to urea. It clears bilirubin by attaching it to bile. It's just in there cleaning up so much stuff. There's a lot of white blood cells stored in the liver because that's, basically the liver is the last stop for venous blood before it gets returned to the heart. So this is our last filter, basically, that the blood goes through, because the blood's been all used up throughout the body. It's bringing all these waste products back. It's bringing blood. It's bringing drugs back. It's bringing bacteria, fungi, anything that it found. This is our last stop cleaning shop, basically, before the blood gets returned to the heart to get recirculated. So this is where things get filtered out for the last point. So there's a lot of white blood cells in there hanging out, trying to clean up the last little bits of stuff before the blood gets circulated again. It decomposes old blood cells, recycles proteins. It also breaks down estrogens that are no longer needed and recycles them. So, having seen what it can do, and this will get repeated over and over again, let's find out what happens when it doesn't work right. We can see our normal healthy liver. Look how beautiful and pink and shiny it is. It's a beautiful little thing. Although my mom loves liver, and she's always wanting me to try and eat liver, and I'm like, I'm not eating a filter. I'm sorry, it's disgusting. There's too much gross stuff in there. It filters drugs, for goodness sakes. I'm not going to eat it, but she loves liver. Let's talk about the circulation around the liver. Again, this is the venous last stop, basically. You have your big vein returning from your body, so basically it is draining. Everything up from your legs, your whole body circulation is coming back through this way. We're talking about the circulation because this will come very important for knowing some of our signs and symptoms. So before the blood kind of gets diverted out from this main return, goes through the liver, and then goes back to the main return. So this is almost like you have to go through the liver before you can get back. Everything, this is all venous drainage. So none of this stuff is going behind the liver through the vessel here. It's basically bypassing through here. So it's almost like if the I-10 going through Phoenix, instead of going right through Phoenix, broke up into all those city streets. So can you imagine the backup here is if, not the I-10. We could say the I-10. The I-10 coming up from Tucson here. And instead of being able to drive through the city and go out to the West End there, to LA, you had to divert through Phoenix and get your car searched and everything before you were allowed to get back on the highway to go back out to LA. So it's kind of along that line, in that this is the venous circulation from the blood vessels, from the kidney. All this venous circulation is circulating through the liver here. So you can imagine now, if the liver starts having problems, which I'll show you a picture of what the problems look like. Let's say some of these cells are no longer working and some of this venous circulation is now occluded. Now there's a lot of backup back here because it's going to take a lot longer to get through the city and get put back on your way. Because there's not as many side roads open. So this starts to all back up this way. So just keep that idea in mind, because we're going to talk about that as a side effect, and that is the block up. I think I will bring this picture back in a couple of slides too. Let's talk about how we test it. The two main liver enzymes, which you probably already know anyway, but I will review: AST and ALT. Main liver, if the liver's damaged or injured, the liver spill this enzyme into the blood. So AST, ALT shouldn't be really in the blood, and it's increased AST, ALT is a sign of liver damage. So increased AST and ALT is damage to liver. So if you want a note there, put that there. Serum albumin, we just kind of keep an eye on that. The albumin levels are low with liver damage because it's not getting produced. Bilirubin levels will get elevated in the blood because the liver's not doing its job to break down bilirubin and attach it to bile. So the bilirubin just kind of stays in circulation because it didn't get attached to the bile. So serum bilirubin may go up as well in liver damage. Cholesterols, like I said, your HDL, LDL get reduced because 90% of cholesterols are produced in the liver. So if your liver is not working, you're not producing those. And your triglycerides that are absorbed go up really, really high because the bile that usually breaks down these triglycerides is not existing anymore. So your LDL, HDL go down, your good liver, your good cholesterol, your bad cholesterol, both of those go down, but your triglycerides, which are just fat circulating around in your bloodstream, are high because the liver didn't create bile to help break it down, and so now it's circulating. Your PTT is going to be increased because your clotting times, this is your times basically to clot, your times to clot get increased because you don't have clotting factors. So the time that it takes to clot will go up, and that's what those times are, the times to clot. And so they will get increased because our clotting factors. What do you think will happen to our platelets? I didn't write platelets here. I'm going to add those little boys in. What will happen to our platelets? They will drop because of lack of thrombopoietin. Well, you know what I mean, thrombopoietin. I can't draw on my board really well, but platelets will start to decrease in liver damage. So let's talk about what we see. We're going to talk about the chronic liver damage first. It's a little bit more common than acute liver injury. When we did the renal, we kind of did acute kidney injury first, and then we did chronic kidney injury. I'm going to flip it up for you this time around. So we're going to talk about the chronic liver failure, chronic liver injury, which is cirrhosis. So here's a couple pictures of the stages that you go through. And what I really like to point out on these pictures is this one, because remember, these are all venous blood vessels, and these are all the little side streets that the main circulation has to go through and get diverted to. So basically, let's just say every, I'm just making up a number here, but the large vena cava is now filtering through the liver, and there are 1 million side streets to go on. Sounds great, right? So 1 million side streets, we don't have any backup because there's 1 million side streets to go through. It's kind of like going through 1 million checkpoints. It filters things out, and then you get dumped back into the system. So we've got 1 million checkpoints, so there's no backup. But let's say now that we start to deposit fats, which is really what happens. The stages of liver damage, you have a healthy liver, you start getting fatty deposits, and then scar tissue starts to form, and then you basically have destroyed liver cells. So there's a couple of stages there, and again, I'm not making you memorize the stages, but what I want to show you here is let's talk about these checkpoints. So let's say we had 1 million checkpoints, but now we lose a checkpoint. That checkpoint's no good, that checkpoint's no good, this checkpoint. So now we're like basically reducing our checkpoints, and we start ending up with a great deal of backup. We still have the same amount of blood trying to filter through, but now we have less usable checkpoints to make through. So now we're starting to have that backup in the liver. So the liver itself starts to swell with backed up venous blood until it can handle the cleaning of it. So the liver itself will start to swell, and then these vessels, basically, if you keep damaging them, or they continually have damage. So basically, what's damaging these? In most cases of cirrhosis, it's either high levels of fat that's damaging these cells, that's causing blockage of these areas, or it's toxins. So you do a lot of IV drugs. You drink a lot of alcohol. Well, every time it defoxifies, it kind of knocks out a checkpoint for a little while. The liver has an amazing ability to regenerate itself. So let's say you go out on the town and let's take our healthy, normal liver here. We go out on the town and we drink, 3 bottles of vodka because we had a really good night, a hangover Vegas kind of weekend. You knock out a whole bunch of these checkpoints, but then you know what? They regenerate. So eventually this one will regenerate. This one regenerates, this one regenerates. So every toxin that you clean out, or you take a lot of drugs, you take, you have a fever and you take a whole bunch of Tylenol. Tylenol causes these cells to get kind of knocked out. Every time we do, a detoxification, it takes these cells out for a little while, but they regenerate and they come back. With enough damage, they keep getting knocked out. And so they regenerate kind of badly. They regenerate into fatty cells. They regenerate into just dead cells. They're just like, you know what? I'm tired of getting destroyed. I am out. I'm quitting this job. So you have a lot of necrotic cells that just don't regenerate anymore. Maybe they regenerate poorly. And so you basically start knocking out these checkpoints. Whereas if you just do it once, okay, those toxin cells, those cells that get destroyed by a toxin, they get fixed. And then they're open for business again. And we have 1 million of these checkpoints. So you can knock off a bunch of them. You may, you may knock down function for a little while, but the liver can regenerate itself up to, I think it stops regenerating at like 10% function. You can destroy it all the way down to 10% and it'll regenerate. You can, they've had transplants where they just transplant partial kidneys and they regenerate. Not partial kidneys, oh my gosh, partial livers, and they regenerate. The liver is an amazing regenerative organ, but if you keep abusing it, it starts finally shutting down checkpoints. It just gets toxified to the point where the cell can't regenerate itself anymore. And that's where you start getting fibrosis, scar tissue. It's just exhausted trying to regenerate itself, and it regenerates poorly as a scar tissue, just like if you pick at a scab numerous times. If you pick at a scab and you keep interfering with its healing process, it will turn into a scar. The liver does the same thing. If you keep picking at its scab while it's trying to heal, it will turn into scar tissue. So really, cirrhosis happens over a long period of time and involves either repeated toxins that just keep damaging it and it doesn't get a chance to heal, and that leads to cirrhosis, which is basically a whole bunch of necrotic, dead, useless liver cells. So let's talk about what you see now as you destroy your liver. So you're not destroying your liver, right? Everyone's decided, I'm not destroying my liver anymore. And most patients have no symptoms until the liver damage is extensive, till basically, 90% of it has become necrotic. So no symptoms until liver damage is extensive. So you can be having this go on for decades before you start to see it. Just like with the kidney, we don't really start to see symptoms until you're in stage 3 of liver damage. With cirrhosis, you don't even really start to see symptoms until you're really late into it. There's no specific stages for cirrhosis. What they will do is they do stage it they will do a biopsy of the cells and see if it's in fatty or fibrosis or cirrhosis. So they do stage it, but it's in these, you don't need to memorize the stages. But a fatty liver is much more regeneratable than a fibrotic or a cirrhotic liver. But let's talk about a damaged liver to the point where we're seeing symptoms. What are we going to see? Well, liver cell damage causes liver congestion because now we've shut down a whole bunch of checkpoints. So now these necrotic liver cells are letting off a lot of AST and ALT. They're like, we're damaged, we're done. Bilirubin starts to rise because bile's not being produced as much, and it's just staying in circulation, basically. We end up with what's called portal hypertension. This is not hypertension that's going to change your blood pressure. It's hypertension, meaning that you have a lot of pressure in these veins. And portal veins are liver veins. So you have a lot of pressure in these veins, and that means your liver is swelling. So when you have portal hypertension, you have a lot of venous congestion or backup in the liver. So you're going to get edema of your liver because when vessels are under a lot of pressure, especially porous ones, fluid will leak. And so fluid leaks into other liver cells. which of course then damages our liver cells, but you get a swollen liver. So it's called hepatomegaly, is a swollen liver. You can even have a visible liver, or you can have palpable liver margins where you don't normally feel your own liver when you're palpating under your rib cage. But here maybe you could actually see a bulge under your rib cage, or you could palpate it. You might get abdominal distension, mild ascites. So what we're talking about there is maybe this lovely lady here. You can actually see the portal veins on this woman. This is an actual result of backup. And as these vessels, they're not just varicose. I mean, some of them are on the surface, but we're actually seeing vessels here. And if the vessels are this swollen and under that much pressure, they're going to leak out. And they leak out into the abdominal space. Normally, we would back up and start leaking out in the peripheral, in the tissues where they're the weakest, in the hands and the feet. But here it starts, the pressure is so high just right there in that abdominal space that the fluid leaks out in that abdominal space. So that is all caused by more congestion, venous congestion from the liver, because we are shutting down cells that the blood usually flows through. So that is what we see. So portal hypertension, when you see the word portal hypertension, it means venous congestion of the liver. And hepatomegaly is a name for a swollen liver, basically. Hepata means liver. So anything hepata means you're dealing with the liver. And megaly means big. So it means big liver. So that's just congestion. So we've got a lot of swollen venous congestion, swollen liver. We also have a decreased production. And again, as the damage gets worse and worse, we have less and less production. So the first thing we're going to see is a lack of bile, right? We produce bile. So what happens when we don't produce bile? We have an increased bilirubin. We already took credit for that. And we have a lack of bilirubin getting carried out of our liver into our intestines. So remember, we said bilirubin makes our stool brown. So without bilirubin, where's the bilirubin? Circulating around the bloodstream because it never got taken out. So with the lack of bilirubin, your stools actually become pale or gray. So it's called acholic stool. It's pale or gray stool, and that is due to the lack of bilirubin. And the reason we don't have bilirubin is because there's no bile carrying it out of the liver. So the bilirubin just kind of hangs out in the bloodstream. Steatorrhea, meaning a fatty diarrhea. Steatorrhea means fatty diarrhea because bile does help digest fat. And so if we don't have any bile not being produced, then we will have a lot of fat making our way through our intestine, and you end up with fatty diarrhea. We have fluid retention in abdominal tissues, not only because of portal hypertension, but because of a lack of albumin. We don't produce albumin. We don't have nice thick stuff to stay in our blood vessels. So when the blood vessels don't have anything thick to attract fluid into them, fluid leaves. And so we will have fluid retention in our abdominal tissues due to lack of albumin. You can also have peripheral edema, but the lack of albumin usually creates fluid retention in our abdominal tissues, and that's because there's no albumin circulating around. Fluid leaks out of the bloodstream constantly because there's nothing to attract it to stay in the bloodstream. So there's fluid retention mostly in the abdominal tissues, but you can have peripheral edema as well. Increased bruising because we're not producing clotting factors and platelet production, so now we have a lot more bruising, frequent nosebleeds, and that's all due to the lack of bile, the lack of albumin, and the lack of clotting factors. We can't store, so you end up with anemia because you can't store iron and B12, which are needed for red blood cell production. You get malnutrition because you have decreased storage of vitamins and minerals. And you're like, but what about the big sign or symptom of cirrhosis? Don't worry, it's coming. The big sign or symptom of cirrhosis is jaundice. Of course, the medications stay active longer. The detoxification centers are shutting down. Things aren't working. So decreased medication breakdown. So that means your medications stay active longer because they didn't get broken down. So your narcotics that you give them will remain working longer than they're supposed to. The antibiotics that you give them don't get broken down right away. So they end up becoming stronger because they last longer. Medications no longer will stay active longer, and they don't get decreased as soon. So, of course, if you're using regular antibiotic doses in a liver that's not breaking it down, the liver hasn't broken down the first dose of antibiotics before you give the second, and you end up getting toxic on your meds very easy with a bad liver. Jaundice is the one everyone wants to think of, and this is due to excess bilirubin. Again, it's now circulating in your bloodstream and getting deposited into random tissues rather than being carried out by the bile and dumped out in your poop. So now you're seeing yellow. You usually see jaundice first in the whites of the eyes, and then it starts showing up more as a yellow tinge to your skin. And the yellower you are, the worse your bilirubin level is. The kidney will take care of getting rid of some of that bilirubin, and it will change your urine from yellow to tea-colored. So you don't normally, sometimes it looks concentrated when it's really not. It could be just bilirubin. So a lot of liver patients with jaundice will have tea-colored urine because the body's trying to excrete that bilirubin. But anyway, this is all due to lack of bile and bilirubin hanging around. And so we'll deposit it in other places. Elevated ammonia. Ammonia is supposed to be, and bilirubin is due to a breakdown of blood products. Remember, our red blood cells are going to break down on a timed schedule. Actually, you probably haven't had that yet. We don't do that till we do the anemia section. Red blood cells last 3 months, and then they just break down. So we're constantly having red blood cells recycle, and that's what's causing bilirubin, is our red blood cells breaking down. Ammonia is due to breakdown of protein. So when we break down protein, it makes your ammonia, and we're supposed to convert that ammonia to urea. And so when you have ammonia not being converted to urea, well, there's nothing for the kidney to excrete. That's the blood urea and nitrogen. Urea is it's a waste product. It goes away. It is a byproduct of basically proteins breaking down, turns into ammonia. The liver converts that ammonia into urea, and then that gets excreted by the kidney. But when a broken liver, that ammonia never gets converted to urea. So you have a decreased blood urea nitrogen because you have a lot of ammonia circulating around. The liver didn't do its job to take ammonia, which is toxic, and break it down to urea, which is semi-toxic, but not as toxic. And then the kidney is it recognizes urea and gets rid of it. So we have a lot of ammonia running around that we don't normally have. Normally, we never have ammonia running around in our system because it's immediately converted by the liver into urea. We have a lot of estrogen roaming around now. The liver is supposed to break down estrogen. So the extra estrogen then gets deposited in places, causing these skin changes, which looks like these little spider veins here. These are spider angiomas. Those are due to increased estrogen levels. Palmar erythema is due to increased estrogen levels. And of course, in men, it is associated with gynecomastia, which is breast tissue growth. Could be impotence, testicular atrophy. It's basically due to men with liver damage have increased estrogen levels. And women who are supposed to have fluctuating estrogen levels now have very high estrogens, so they will have changes in their menstrual flow. They could have heavier bleeding than normal. They could have no bleeding at all. Basically, an imbalance of estrogen will cause all these signs and symptoms. So we have congestion, swollen liver. We have problems with our production our storage stuff. So we have, let's go back. So let's review it real quick. So cirrhosis, just having it, and having it symptoms means you're pretty late stage already. Increased enzymes, swollen liver, portal hypertension. Our big products are clotting factors. So you have bruising, nosebleeds, because you just don't have as many clotting factors. Your clotting times go up. You don't have albumin, so you end up leaking a lot of fluid. You don't have that thick protein in your blood vessels. You don't make bile, so bilirubin doesn't get carried out, and you also don't break down fats as well. And then because bilirubin is not being taken out, you have jaundice. It's also known as icterus, so if you hear icteric, icterus, Icterus is, I like to think of, if you've ever heard the Greek legend of, it's not Icterus, but it's Icarus. That's how I remember him. Icarus was the one that flew too close to the sun and his wings melted. So if you ever want to look up a fun bedtime story for your kids. But Icarus flew close to the sun, and the sun is yellow. So I remember that Icterus is like Icarus, and it's sunny and yellow. So anyway, jaundice is yellowing, but if you ever see the word Icterus, that means jaundice as well. So anyway, we have a lot of things that were supposed to be taken out of our body by the liver that are not taken out of our body anymore. One of them being bilirubin, one of them being ammonia, one of them being estrogen. And then, of course, our meds stick around longer, too. So what happens? That's bad enough, right? Let's say that things are getting worse, okay? Things are getting worse. So let's talk about our venous congestion getting worse. Well, as venous congestion is getting worse, more cells are damaging and dying, so our AST, ALT are going up. Our bilirubin really is a waste product. I should probably put bilirubin under the waste product category, but it is going up as well because we're not removing it from the system the way we should. Varices come to us now, esophageal and gastric varices. Let me see if I have my portal picture. Oh, I'm going to have to draw you a portal hypertension picture. So that's the same picture as where we have our liver and we have all those little blood flows through it, and then we have our portal vein coming out of here. We've got our vena cava. But remember all those veins that were dumping into it from the esophagus and from the stomach? We had a lot of veins. And so this is not only backed up into our liver, it's backed up into the portal vein here, and now it's backing up into our esophagus and into the venous circulation around the esophagus and the stomach, causing these vessels to become distended. And those distended vessels actually show up in our, this is a picture of an esophagus with a distended vessel kind of poking into it. That's known as a varice. So esophageal and gastric varices are just swollen veins that are basically protruding into what's supposed to be a hollow space. The danger of that is that we've got veins now bulging into our esophagus and into our stomach. And varices themselves are just swollen veins. But can you imagine now you eat a piece of steak and it scrapes right by that? They have a high risk of being scraped up and rupturing and bleeding. So esophageal and gastric varices, the existence of them means that it is worsening portal hypertension, meaning that portal vein is getting distended and it is backing up further into the veins around the esophagus and around the stomach. So we have varices. The existence of varices means you have super high portal hypertension, meaning you don't have blood flow going through your liver very well. So this is worsening portal hypertension. Just before it was a swollen liver, but now it is swelling not only your liver, but into your veins from your esophagus and your stomach. So esophageal and gastric varices are signs of worsening congestion in the liver. Hepatorenal syndrome is something that happens at the very, very end stages, that basically there's acute renal failure caused by total liver failure, and that's because the venous congestion backs up as far into the renal veins, not the renal arteries, but into the renal veins and cause kidney damage. And so that's very, very end stage. So basically, as things get worse, first you'll see the AST, ALT, bilirubin going super high. You will possibly, if they do a scope or they have an episode of GI bleeding, you will see these varices in the esophagus. The decreased production things, remember we produce bile, albumin, and clotting factors. So albumin, the lack of albumin creates these ascites, which are even worse. So you can see these lovely, beautiful men here have ascites, which is basically large abdominal, what looks like distension, but this is all fluid. And when these ascites get so big, they end up pressing on the diaphragm and causing shortness of breath. So you can have ascites during regular cirrhosis, but when the ascites starts causing shortness of breath, we have to do something about them. And the ascites exist because we have decreased albumin levels and portal hypertension. Pulmonary edema, because again, we are lacking albumin, stuff is leaking, and now we're starting to leak into our lung space. So pulmonary edema, pitting edema, now we're not only just leaking around our abdominal area, we're leaking out, the venous congestion is getting so bad that we are leaking out pulmonary pitting edema. And then, of course, lack of clotting factors and increased risk for things rupturing creates a much higher risk of bleeds. And late cirrhosis patients or worsening cirrhosis patients have a lot of GI bleeds because they have a lot of varices that rupture. So one leads to the other. So the varices ruptures leads to a bleed, and then you don't have clotting factors, and so you end up with quite an extensive bleed. You can also have hemorrhagic strokes, or you can have large amounts of bruising. But the worsening cue, really, that we're seeing are those varices bleeding and not having clotting factors. They're not able to store, again, severe anemia. We need iron and B12 to create good red blood cells, and that is not being stored. So severe anemia, malnutrition, you get muscle wasting due to the fact that we don't have any protein, so the body starts breaking down muscles to get proteins because we're not creating albumin. Brittle bones, basically due to malnutrition and decreased ability to store stuff. And the body breaks down muscles and fats to get what it needs if you don't have the nutrients stored. And then for our decreased cleaning, what do we clean up? Well, medications. Medications stay active longer. Jaundice starts getting worse. That's the bilirubin that we're not excreting. Jaundice is getting worse. The urine's becoming tea-colored because it's just getting out, and we're trying to excrete bilirubin anywhere we can. So that lovely yellow man at the top there has excreted a ton of bilirubin into his tissues. One of the most dangerous things is that ammonia. Remember how we said that the liver's supposed to turn ammonia, which is normal protein breakdown. It's supposed to turn ammonia into urea. Ammonia is a toxin. I mean, you wouldn't breathe in ammonia. You use it to clean things. It is certainly not meant to be running around in our bloodstream. And the problem with ammonia is it crosses the blood-brain barrier very easily and starts affecting the brain and the nerves. So one of the first signs of having a toxically dangerous ammonia level, and we call that hepatic encephalopathy. Encephalopathy means that you're just not maintaining appropriately, you're confused, and it's not because there's something going on in your brain. It's a toxin, basically. It's a toxic brain. So think of encephalopathy as toxic brain, and it's due to ammonia. So it's called hepatic encephalopathy because it's due to the liver not removing ammonia. But ammonia is a terrible toxin to the brain. The first sign of it is nerve damages, and it's a muscle flap. Look up on YouTube. I thought I had a link for it, but I guess I lost the link somewhere. Look up asterixis. What it means is when you hold a hand up like you're going to do a stop motion, your hands flap. You have no control over it. It's kind of like a reflex that shouldn't exist, but it exists when you have ammonia circulating around in your bloodstream. So it's a sign of a high ammonia level. So if you hold up your hands in the stop position, like you got two hands up that you're trying to tell someone to stop, two hands up, and hopefully your hands don't flap. Your hands should stay up in the stop position. If you have asterixis or an increased ammonia, your hands will flap. And so watch a video on asterixis just so you see it. But if you see the word asterixis, it goes with ammonia, and it is a sign. It's the first sign of a high level of ammonia. The second level of a high level of ammonia is your brain starts to shut down. You start getting combative, confused, disoriented, and then it goes to lethargy and coma. So I will tell you, your liver patients with high ammonia levels, they are acting out. It's not them. It's the toxin that's circulating around in their bloodstream. So this is the patient that's climbing out of bed, doesn't know where they are, they're being aggressive, and then they finally fall asleep. And you're like, yay, you fell asleep. No, they got super high ammonia levels. So it's not their fault. It's the toxin that's circulating around, but it causes confusion, disorientation, aggressive, inappropriate behavior, again, due to high toxins in the body that's eating up the brain, and will progress to lethargy and coma and brain damage if we don't get rid of the ammonia. So when your confused, combative, jaundiced patient starts sleeping for long periods, even though you yourself as a nurse want to celebrate this, you need to treat it because it is probably in a high ammonia level. So those are our worsening conditions for cirrhosis, and probably the worst things that can happen to your cirrhotic patient. They have these giant varices. Not having them isn't that dangerous, but when they rupture, it's dangerous because they will continue to bleed without their clotting factors. These ascites get out of control, get really large. They can have pulmonary edema. So basically, the varices that have a high risk of bleed, the bleeds that don't stop, pulmonary edema is dangerous. Jaundice itself is not dangerous, but but ammonia is. So, jaundice, it'll deposit and it'll make you a fun color, but it's not particularly dangerous or toxic to your brain the way ammonia is. So we're very much more concerned about the ammonia level on a worsening cirrhotic patient. So to monitor all these things, we're going to monitor lab work, not just the AST, ALT. I mean, once you have AST, ALT going up, we know we have cirrhosis. We know it's going to be high in cirrhosis. If we have a cirrhosis patient, we kind of don't even follow. We know they're going to be high. What we're interested in is the ammonia level, because that one's the severe toxin. We're going to be keeping a very close eye on the ammonia level. We're going to be keeping a close eye on that albumin level because our fluid retention is based on how low our albumin goes. So we'll have more fluid retention the lower our albumin is. Again, bilirubin, we can trend it, but we usually see the yellowing on the patient, so we know the bilirubin level's high. If the patient's yellow, their blood bilirubin's going to be high. I mean, that's not going to be magical information for you. Platelet level, PT, PTT, we expect them to be high. We don't expect them to be dangerously high, causing no clotting. So really what we're trending on our cirrhosis patients is our ammonia, our albumin, and probably our clotting factors. And we'll look at the H&H because if there's a bleed under the surface somewhere, it'll show up in the H&H. So we're definitely watching those things. The AST, ALT, we know they're high. The bilirubin, we know it's high. That's not going to tell us really a whole heck of a lot. But ammonia will tell us why our patient's getting confused. It'll tell us whether we're effectively treating the ammonia level. Albumin level we'll need to treat. And the bleeding risk that we have, we want to look at those. Of course, skin, we're going to see jaundice, bruising. The more yellow, the worse farther along. I mean, you can tell the color of your patient will tell you how far along in cirrhosis they are. If their amount of bruising goes up, we need to worry about that. Blood pressure, heart rate, peripheral edema, daily weights. Again, the yellower your patient is, the more ascites they have. It just tells you basically the degree of cirrhosis that you have. Blood pressure and heart rate, we're watching that because as the flow through the liver gets blocked up below the liver, what do you think is returning to the heart? A lot less blood. So we actually have a lot less circulating blood returning around. So we might see the blood pressure drop a little bit. We might see the heart rate increase a little bit. You'll also be worried about those if you're having bleeding somewhere with your blood pressure dropping, your heart rate increasing. It means you've got less blood flow circulating around. If you have a low blood pressure, high heart rate, and huge amounts of pulmonary edema, pedal edema, portal hypertension, your patient, if you give them a ton more fluid, it's just going to exacerbate the fluid not returning to the heart. You have to treat the liver disease and treat the problems with your fluid shifting, because just dumping fluid into the system isn't going to help. It's all going to get stuck. Every fluid that you give them is going into a vein. It's going to get stuck behind the liver. It's not going to really return to the heart. So when we're watching these things, we know we're intravascularly dry. We have to do a treatment that's going to help, not just dump more fluid into the system. So we'll talk about our interventions in just a minute. We'll look at our bowel movements. The grayer and paler they are, the less bile is being made by the liver. Any blood, any bleeding in the stools will tell us that we might have a GI bleed somewhere. If they have ascites, we're going to be watching the abdominal girth. we're going to be watching. That's the way we measure how much ascites you have, is how much the abdomen grows. Definitely watching the neurostatus. That will tell us if the ammonia level is high. I could tell you by how combative a patient is, how high their ammonia is. And respiratory, we're worried only really about the pulmonary edema or the shortness of breath of ascites. I guess we should probably write in there lung sounds as well. Sounds for pulmonary edema. Okay. So I think that's why we're monitoring what we're monitoring. We're looking for worsening conditions of our patients. So here's the meat. What do we do for our cirrhosis patients? If you do not have worsening cues, so you don't have varices, you don't have severe ascites causing shortness of breath, you don't have bleeds, you have jaundice, maybe yellow tinged jaundice, you maybe have steraturia, maybe you've got those existing signs, not anything worsening yet, then you're going to maintain, you're going to try and control your liver damage and manage venous congestion. So, of course, avoiding alcohol. So as soon as you enter into any kind of liver damage, increased AST, ALT, you need to stop alcohol. So tell an alcoholic to stop alcohol and see how well it works. But you tell them, avoid alcohol, because you're just continuing to damage the problem and you will make it worse. Beta blockers will cause vasodilation and are actually very well treated for portal hypertension, will help dilate those vessels out and allow them to hold more so that they're not causing as much venous congestion. They're not causing varices. Will prevent varices, hopefully, with beta blockers. A low sodium diet, because you already got a lot of fluid overload. We don't need to add sodium to it to retain fluid. You've already got enough of a problem. So you've already got problem with venous congestion. Avoid alcohol. Low sodium diet will keep more fluid from joining the party, and beta blockers will help that fluid from causing varices and other problems. In terms of production, we can't really produce things for the liver. The only thing that we can replace of the liver's functions is albumin. We can replace albumin, IV. They spin it down for blood transfusions. You can get albumin. It is considered a medication, not a blood transfusion. So we can physically give the patient with a low albumin level, we can give them albumin. Albumin is a super hypertonic, super thick product. So when we put IV albumin into the blood vessels, what is it going to pull into the blood vessels? It's going to pull fluid into the blood vessels and out of the tissues, which is going to reduce our ascites. Yes, it will still cause problem with venous congestion. We will have a lot of blood. You do need fluid in your blood, but it will help reduce our ascites and keep your albumin level normal. So patients can get albumin replacement, but what you're going to do is you don't have bile. You're not producing bile, or you're producing small amounts of bile. So we want a low-fat diet because bile helps us to digest fat. So we want a low-fat diet because if we don't have enough bile, we don't need to be doing high fats because we can't digest them. You'll end up with just steatorrhea, and just as soon as you eat a fatty meal, it's going to come out the backside because we didn't digest it. So low-fat diet. Don't give any more work to your body that it can't do. In terms of biles need to get rid of bilirubin, we really can't do anything about that. We can't do anything about the fact that our blood cells regenerate every 3 months and that we will constantly be having red blood cell breakdown. There's not much we can do about that, but we need adequate protein. Now, we don't want too much protein. A liver patient cannot be on a high protein diet because what does protein breakdown turn into? We break down protein, it turns into one of those waste products. It turns into ammonia. So high proteins will cause more ammonia and worsen cirrhosis. So a liver that cannot do a good job of converting ammonia to urea, we certainly don't want to put a lot of proteins into the pot there. But you still need adequate proteins, because if your body doesn't have protein, it's going to break down muscles to do that. And So we want adequate protein. We do not want too much protein, because too much protein will lead to an increase in ammonia, which does not get converted to urea and could increase your ammonia level really high. So adequate protein diet. Bleeding precautions, because we can't really, we can replace platelets and plasma to give us our clotting factors, but we're not going to do that unless the patient has an active bleed. We're just going to know that they have a high risk of bleeding and teach them a few things, which I have on a slide, on how to control bleeding. They're the same precautions that you teach a patient with anticoagulants to do. They should take vitamins daily. They don't have storage facility, so they will take daily vitamins to avoid malnutrition, but know that you're never going to store them, so you might need higher doses on your daily regimen. Because it detoxifies meds, you're going to really have to watch your med doses. Antibiotics, narcotics, Tylenols, nonsteroidals, any medication that you take, you should talk about adjusting the doses, knowing that they're going to last in your body longer. And if you use normal doses in liver failure, you could add to damaging your liver, especially if it's trying to metabolize a bunch of different drugs. So watching your medications with any kind of cirrhosis is very, very important. Watching those medications with your doctor. Adequate hydration. IV fluids. Remember, your kidneys will get rid of some bilirubin. Just go ahead and flush that system out. Hopefully your kidneys are working if your liver's not. Adequate hydration, IV fluids to flush out that bilirubin and jaundice. Because if you keep your bilirubin getting flushed out through your kidneys, then you will keep it out of your skin and you won't be as yellow. So hydration fluids will help get rid of the bilirubin that's running around. We give lactulose to control the ammonia. So if you're eating a ton of protein, or you start getting confused, you get that asterixis showing up, that is a sign that your lactulose level or your lactulose dose is probably not adequate. Lactulose binds ammonia in the gut and you poop it out. Any patient with cirrhosis should be on lactulose to keep their ammonia level under control. And it's important that they know about asterixis, because if they start having asterixis, that's the first sign of an increased ammonia level, and that means your lactulose dose is not effective. So definitely they will need to be on some kind of lactulose. It's not a temporary thing. Your liver cannot break down ammonia, so you have to get rid of it another way, and that's how we do it, is with lactulose. So lactulose is your big drug with any liver cirrhosis. And again, adequate protein, because we don't want a lot of extra waste. So if you go out and eat a 40-pound porterhouse or 40-ounce porterhouse steak, your lactulose dose is not going to be effective, because you just made a ton of protein breakdown. Your ammonia level is going to go sky high. And if you were taking lactulose dose that would manage normal proteins, that dose is not going to be effective. You might end up with some asterixis or confusion or something if you go out and overeat your proteins. So here's a little, bleeding precautions. Again, I'm sure you've seen bleeding precautions somewhere along the lines when you do anticoagulants. Look at your stools for blood. If you are having problems bleeding, it's usually your first sign of a GI bleed is some blood in your stools. Frequent nosebleeds, gum bleeding, a lot of extra bruising. Just keep an eye for those things, and limit needle sticks. Try not to do, this is where you're not going to be doing contact sports, things like that if you're on bleeding precautions. So let's talk about what we do when things get worse. We tried. They were taking their lactulose, but they just didn't stop drinking their alcohol. And then they forgot a couple lactulose doses. Things got worse. They started getting encephalopathy. They started getting foreportal hypertension. So we've been watching these ascites and doing the abdominal girth, but now these ascites are starting to cause, shortness of breath because they're so big, and they're carrying a 9-month child in their belly. It's just a fluid child rather than a real child. So we have venous congestion. So anytime we have a lot of extra fluid to deal with, we can do diuretics as long as our kidney is working. We can just fine, you know what, we're going to get rid of the extra fluid. We're going to unload it from the portal system because we're trying to avoid varices that bleed. So diuretics, that's especially important if you're starting to have pulmonary edema or, any kind of peripheral edema. Diuretics will be key. We try not to keep our patients on diuretics, but certainly in short time, or if you have worsening cues, you'll probably be added to a diuretics. We'll talk about paracentesis. This is what we will do to drain ascites. It's where you put a needle into the abdomen and drain out all that acidic fluid. There is a procedure you can do in the endoscopy lab or in surgery where they create a bypass. Because remember, I told you this is kind of like the I-10 going through Phoenix, right? So, we came up from Tucson and we had to go through the city. There were 1 million roads to take, but now there's only 5. So now there's a huge backup on the East Valley because the I-10 from Tucson is way backed up. So, they build the 202 that goes around and everything flows a lot better because now you don't have to go through the city of Phoenix to get out to the other side of I-10. So they basically build a bypass around the liver. Now that means if you're on the bypass, you don't go through the city to get filtered. So remember, bypass fluid is not being filtered as adequately, but it will relieve the pressure in that portal circulation. So basically, putting a TIPS procedure in is creating a bypass through the liver or around the liver. So that's probably the best way I can think of it, is that, the I-10 just basically stops at the 60 and you start taking surface roads all the way through to the West Valley, and there are no other bypasses. That's what the liver looks like. But when it gets so congested that you can't, they create a bypass, and that's what a TIPS procedure is. And then at the very end stages, you could get a liver transplant if your cirrhosis was non-alcoholic related, which will fix all the problems. In the meantime, and to deal with so that's just managing the venous congestion. Diuretics, paracentesis, TIPS procedure, liver transplant. Let's talk about our lack of production. We're not producing clotting factors, platelets, albumin, and bile. So we can put albumin back in the patient. Great. These patients might be on Q8-hour albumin, Q12 albumin, Q-day albumin, whatever it is. They're measuring the albumin level, and if it's low, they're replacing albumin because we've got that. We can give it to them. That's amazing. For clotting factors and platelets, this is where we would now start thinking about they've got worsening cues, which was probably a bleed. We can do blood product replacement when they're having worsening cues. We're not going to do standard blood product replacement. We're going to save that for if they're having bleeds. GI bleed interventions, which we talked about in the, which is just fluid and bloods really, but we did talk about GI bleeds in the intestine section. So we can replace clotting factors, platelets, albumin, and unfortunately for bile, we can't come up with a replacement for that. So we have to flush out bilirubin. We'll continue to do that. IV fluids will help us flush that out, and that'll take care of bile and its job of removing bilirubin. Decreased storage, again, IV fluids with vitamins and minerals. I don't know if you've ever seen the yellow banana bags, we call them. They have thiamine, B12, I can't remember what else, folate. They've got a couple of our non-storable vitamins, minerals in it. So liver patients with worsening cues will get these IV fluids with the vitamins and minerals in them. Maybe supplemental nutrition if we need to get them adequate protein, so to avoid muscle breakdown. Of course, we're going to continue to adjust our medication dosages, IV fluids to flush jaundice and wastes, high doses of lactulose to get rid of the ammonia, because really our big problem becomes ammonia. Jaundice is not particularly damaging, but ammonia is. So our lactulose doses may need to be increased in patients with worsening symptoms. Fun fact, if you are having a GI bleed, so the picture at the bottom there is a beautiful varices that has popped and ruptured and is just bleeding. If this is bleeding into your esophagus here, half of this blood you may vomit up. It'll be bright red. Some of it may be draining into your stomach. Will turn out to be coffee ground because the blood's sitting in your stomach. Some of it may pass all the way through your intestines and come out as black tarry stool. So they may be vomiting and pooping blood. It's beautiful. It's amazing. But blood in the intestinal tract creates more ammonia. Yay, because we already have a problem processing ammonia. But when you have a GI bleed, blood digested in the digestive tract increases ammonia levels. Because guess what? It's red blood cell breakdown. It increases jaundice. It increases ammonia. It increases a lot of the problems that we have because the blood should be in the bloodstream, not in the GI tract. But the GI tract will digest it and put it back in the bloodstream. So broken down red blood cell components. So GI bleeds actually increase your ammonia and increase your jaundice. So yay, we already have problems. So our GI bleeder, because they have varices and no clotting factors, they're just fun patients. I'm going to tell you, being in the ICU, having a bleeding cirrhosis patient, that is an amazing job. One of my favorites. But high doses of lactulose. And guess what lactulose, I think I have it in here. Lactulose causes diarrhea. We're not allowed to hold it. So this is not a med they're giving for constipation. Lactulose causes diarrhea. And it's binding ammonia and throwing it out there in diarrhea. So here you go. You had your crazy, combative, confused, disoriented, yellow patient who's GI bleeding and pooping and throwing up blood. And you're trying to give them blood products. And they kind of pass out, and you're like, oh, thank God you finally fell asleep. And you're like, oh, no, their ammonia level's really high. This is not good. All right, I got to give them their lactulose. So you give them their lactulose, and it starts binding the ammonia, and they start pooping. Now they have diarrhea on top of all this stuff. And so they have diarrhea. So as your ammonia level drops, it doesn't drop to perfect. It drops to crazy. So your ammonia level drops from lethargic and coma to crazy, and now your disoriented, combative patient is back. Now they're pooping and having diarrhea and still bleeding, and you're like, I love my life because I fixed a patient. Because now their ammonia level's down. I did a good job. But now I got to go in there and make sure he doesn't slip on his poop and blood. Yay, nursing. It's great. So just funny, you'll remember that on a test. I know you will. Lactulose causes diarrhea, but we need high doses of lactulose to get rid of that high doses of ammonia, because really our patient dying of hepatic encephalopathy and brain damage because we didn't give them lactulose probably doesn't feel so good at the end of the day for good therapeutic interventions. So chronic alcohol abuse, we know, is one of our big causes of cirrhosis. Chronic viral hepatitis, which we talk about in a minute, hepatitis B, C, and D. Those are our chronic hepatitis. Chronic infections of the liver, which is what they are, can cause cirrhosis. Non-alcoholic fatty liver disease is usually a genetic problem, and excess fat accumulating in the liver can cause blockages in the liver. And then there's a couple other random little things. But really, alcohol abuse and viral hepatitis are our two big causes. And then non-alcoholic fatty liver disease. It's also known as non-alcoholic steatohepatitis. It's called NASH. And that's usually just genetic. We've had people in liver failure that have never taken a drop of drink in their lives. For having hepatitis or non-alcoholic fatty liver disease, those are the patients that get liver transplants. Our chronic alcohol abuse patients don't qualify for a liver transplant unless they've been sober and have been taking care of themselves for a long time. So the diet, we talked about low sodium because we have a lot of fluids, low fats because we don't have a lot of bile to digest them, adequate protein because we don't want muscle breakdown, but we also don't want too much protein because we can't handle the extra ammonia. Stop the alcohol, for goodness sakes. If you're drinking it, stop. If you weren't drinking it, great, don't start. Manage all your chronic conditions, medication dosage adjustments. Don't do anything that is going to cause you to bleed, like Tylenol. Anticoagulants, nonsteroidals. Tylenol is actually very toxic to the liver itself. So most patients with any kind of increased AST, ALT are advised not to do Tylenol. And then they're also advised to do non-steroidals. So what's left for them to take? Well, not very much. Daily vitamins are important because they're not producing as many vitamins. If they're prescribed lactulose, yes, it will cause diarrhea. Do not hold or stop it because you're having diarrhea. Your ammonia level will go up. certainly let them know to report a weight gain or fluid retention or abdominal shortness of breath. So I think that's cirrhosis. Acute liver injury is really, this is not happening over a long period of time, no chronic problems. This is where a previously healthy liver has an injury now, a massive injury. And there's an acute shutdown of flow through the liver. And this is very similar to an acute kidney injury. Most of the causes, or really the two main causes of it, are drug overdose. Acetaminophen is our biggest cause of acute liver injury. So if you take a Tylenol overdose, those are very toxic to the liver. Illegal substances like heroin, narcotics, things like that. Just when you put a lot of toxins into your liver that it has to detoxify at once, we have a massive shutdown of your liver. So drug overdoses is probably the biggest cause of acute liver injury. And then we have acute infections. They're usually viral infections, but acute infections can shut down our liver pretty quick. Abrupt cardiac failure, if your heart stops pumping very well, it backs up a lot of fluid into your liver and can cause like a portal hypertension problem. But really that's not as common. And of course you can have acute liver injury if you had a previously healthy liver, but now it's got a cancer in it. It won't produce very well. So those are our big causes, but really the main causes are the drug overdose and acute infection. We would see most of the same cues, but unfortunately the body hasn't kind of gotten used to things. So things like varices is slow progressing portal hypertension. So we don't see varices in acute liver injury because the body just hasn't had time to get used to that extra pressure. You will have a big swollen liver, 100%. We expect you to have jaundice because for some reason the liver has just shut down right away. So you will have jaundice, you'll have peripheral edema, you may have ascites, but again, ascites grows slowly over time, is basically fluid slowly leaking out over time. The thing about an acute liver injury is that everything happens so quickly. We expect the jaundice, we expect the swollen liver, we expect some swelling, we expect to have increased elevated enzymes, we expect our ammonia to go up. But the biggest problem we have in acute liver injury is the abrupt cessation of blood flow through the liver causes decreased blood pressure and perfusion because the blood's not returning to the heart very well. You get quicker route into pulmonary edema. Remember, in cirrhosis, things move slowly, so a lot of the backup blood flow will go to the GI system. It will create varices, create ascites. Here we don't really have the time for that, so the fluid backup is to places where we don't want. We get pulmonary edema, we get cerebral edema, and then of course you still have your decreased platelets, your bad clotting times, you get active bleeding, and you have a hepatic encephalopathy come on pretty fast. So what we worry about acute liver injury, some people never get to the worsening cues. Some people just have a little bit of liver damage, and you have a swollen liver, some jaundice, some peripheral edema, maybe a little confusion, some asterixis, and that's it. But if you are going to go into what they call fulminant liver injury or severe acute liver injury, you are having problems with your blood pressure perfusion, and you're having your fluid leaking not into ascites and to varices, but into pulmonary edema, cerebral edema. And then combine that with your increased risk of bleeding and your toxic levels of ammonia. A severe, big damage to your liver could cause some pretty acute liver problems. Again, what we're monitoring is exactly the same as what we're monitoring at cirrhosis, but what we're seeing in acute liver injury is this is happening not over a course of 2 to 3 decades, but is happening over a course of a week. And so your body can't handle this change in fluid volume status. But we're still monitoring for all the same things. The treatments are exactly the same as the worsening for cirrhosis. The treatments are exactly the same, but I'm just going to tell you, you're going to find that you move quicker and faster into your worsening symptoms if you have an acute liver injury. So you have the drug overdose patients that, we're going to be managing that severe pulmonary or severe liver congestion. We're going to be managing the lack of bleeding products, the lack of albumin, but we're not so much worried about the steatorrhea. This is not a long-term process. We're worrying about the big things, which is the fluid, the blood flow, and the backup into our brain and our lungs, into the more vital spaces. And acute liver injury, again, the same things as we're going to do the same treatments as worsening cirrhosis. We're going to take care of our liver the same way we do with cirrhosis. But the nice thing about acute liver injury is that if we maintain functions as best we can, we will recover this liver, hopefully. But people who have drug overdose or acute infection that come up with a total acute liver injury could possibly qualify for a liver transplant. It would depend on the circumstances, but certainly from an acute infection, if it causes liver shutdown, you could get a transplant. Drug overdose, it would depend on the qualifications around it, but we have had some Tylenol overdose patients that have gotten liver transplants because they damaged their liver so quickly and so abruptly that they needed a transplant. But really the treatments are almost exactly the same. I just want you to expect with acute liver injury, because it happens so quickly, basically the decreased blood pressure, the pulmonary edema, and the cerebral edema are much more risk factors than things like with cirrhosis. And there's no ascites, or not no ascites, there's less ascites, there's less varices, less the long-term considerations with acute liver injury. And then I just have a quick slide for the kinds of hepatitis, because a lot of places ask questions about hepatitis, and hepatitis is one of our major causes of cirrhosis, and hepatitis is also a cause of acute liver failure. So there are 5 kinds. If you put them on your finger, your thumb, and the A and E, the 2 on the ends are the ones that are transmitted by contaminated food or water. The important things to remember out of the hepatitises are which ones are foodborne, which is A and E, and which ones are bloodborne or transmitted by blood and body fluids, which is B, C, and D. Which ones have vaccines? We have vaccines for everything except hepatitis C and hepatitis E. And the treatments really are antiviral medications and supporting any signs of acute liver injury. You're much more likely to get chronic liver injury with your blood and body fluids. The chronic liver injury is ones that have chronic infection. So A and E are basically foodborne. They last 7 to 10 days and then they're gone. B, C, and D stay and constantly flare up in your liver and cause chronic infection. So B, C, and D are the ones that cause an increased risk of cirrhosis and liver cancers. B and D have vaccines and C does not. So right now, hepatitis C, now that everyone's gotten hepatitis B vaccines for the past 15 years or so, we're starting to see hepatitis B and D kind of go away, but hepatitis C is still around and does cause most of our non-alcoholic cirrhosis is due to chronic hepatitis C infections. All hepatitis have an acute phase, just like every virus. It resolves a week to 2 weeks. Flu-like symptoms. Sometimes you don't even know you had hepatitis, but there is a risk of acute liver injury during the acute phase. And then there's a chronic phase, which only happens with hepatitis B, C, and D, and those chronic flare-ups cause chronic liver damage. So that's all I want to say about hepatitis. And then there's a couple of procedures. I think it's paracentesis and liver biopsy. So we're just going to talk real quick. This was a long one, wasn't it? God, it was only 30-some slides, but I talked a lot. For paracentesis, this is where we are actually draining ascites. This is where we will put a needle in and drain out those ascites. Paracentesis and peritoneal dialysis are not that much different. It's just one is peritoneal dialysis. We're doing it with a purpose. Paracentesis, kind of our body did it to us. But before the procedure, the important things to remember is the patient needs to void. I mean, if you can see kind of in these, we're going to put the needle to drain lower in the abdomen right around where the bladder is. So if the bladder is emptied, there's a less of a chance of bladder puncture. So we're going to go ahead and avoid the patient, have them sitting upright on the side of the bed. This picture here has the patient laying flat, and so I rotated it so that you wouldn't remember the patient laying flat. We don't really want the patient laying flat. We want them at a 45-degree angle or higher, and that's to drop the fluid down low so that when we put the needle down low, we drain out fluid. If the patient is laying flat, the fluid's kind of throughout the belly, and also then the intestines are floating on top of them. So when you puncture the needle in, when they're laying flat, you have much higher risk of reaching the intestines, whereas when they're sitting upright, the intestines kind of float and the fluid drifts down to the bottom. So sitting upright is really important. Measure the abdominal girth before the procedure so that you can assess whether the procedure was effective or not. After the procedure, basically it's a needle and then they drain. The doctor will decide how much to drain out. Sometimes they don't fully drain the abdomen because we don't want to pull out too much fluid. It could cause fluid shifting. So you will have a little bit, they'll have a little bit of pain at the puncture site. The puncture site's usually just covered with gauze. And there should be a little bit of serous. What comes out of here is yellow drainage because all this is fluid. It's kind of a yellowish drainage. And because this fluid, was sitting in the abdominal space, when you do drain it, what might drain out of there is some electrolytes as well. So we do expect a little bit of fluid and electrolyte imbalances. We just dropped out. We just took, and sometimes they'll take, I've seen probably like 4 to 5 liters get taken off of these ascites. Quite a lot of fluid comes off of them when they do this paracentesis. We do not expect bleeding. That means we've punctured something we shouldn't have punctured. We don't want a puncture of the intestine, a puncture of the bladder, or a puncture of some kind of abdominal artery. So those would be our complications, is that we punctured something we shouldn't have. So I'll let you look at those. The key complications are really, we're looking for fluid or, bleeding or fluid shifting. We're looking for infection, things that we're not, urine output. We could puncture through the bladder, make sure the urine is bleeding, not bleeding, make sure the urine is coming out, make sure that that we didn't puncture the bladder and now we've got urine in the abdominal space. Intestines, if we puncture the intestines, you're going to get an abdominal infection. Again, there shouldn't be much interventions after the procedure. If they have fluid shifted and they need fluid, we'll probably do albumin because they're probably low on albumin anyway. You may need to replace some electrolytes because it might have gotten drained out with the abdominal fluid. And really, there's just avoid heavy lifting. There's really not much to monitor afterwards other than for the side effects of an accidental puncture. And the liver biopsy, a lot of cirrhosis patients go in for liver biopsies as part of their checkup process. The only way to really see the stage of liver damage is to take some of the cells from the liver and take a look at whether they're fatty or necrotic and stage the liver. So they might get biopsies every year or so. What's important about the liver biopsy is we are going into a very vascular organ and puncturing it with a needle. So withhold the food and fluid before. They're going to get sedation. Make sure that anything that's going to affect clotting times or bleeding is stopped before the procedure. It hurts to get the puncture, but it shouldn't hurt too bad afterwards. Should mild to moderate pain. They'll have some light pain medicine to be able to take and a small amount of drainage on the dressing, but it should not bleed through. Basically, the big complication after liver biopsy is bleeding. If we puncture one of those large veins or an artery that's in there, we could cause big problems. Those are very large veins in there. So if we puncture one of those by mistake, or the doc punctures one of those we're not doing the liver biopsy, sorry. The physician will do the liver biopsy. We're not doing that. But bleeding is our big complication. The liver does sit underneath the diaphragm, so if you're puncturing up high in the liver, you could puncture the diaphragm or puncture a lung. Not very common. Bleeding is our most common problem. If you get an infection in the liver, you could have an acute liver injury, peritonitis if you puncture through an intestine instead. But these are done under ultrasound. The chances of those are pretty small. We're mostly worried about the vascularization and the bleeding after a liver biopsy. So we're really looking for signs of bleeding. After the procedure, they need direct pressure immediately on this site, and the liver is on your right side of your abdomen. So you are going to put pressure on the liver, and the only way we can put pressure on the liver is have you lay on that right side with a pillow under there to put pressure on that liver to get any bleeding stopping. They shouldn't take anything that would increase the risk of bleeding or cough, lift, strain. We don't want to pop any of those vessels or anything like that. So after you puncture a highly vascular organ, we just want to make sure that they are not bleeding. So you're going to teach them when they go home, don't take anything that will increase your risk of bleeding. Don't cough, lift, or strain for a while. And if you do have any bleeding, it will be very... it will first irritate your diaphragm because your liver is right underneath your diaphragm. So any bleeding in that area is going to irritate your diaphragm. And irritating your diaphragm causes pain in your left shoulder. So any diaphragm injury or any irritation to the diaphragm causes what's called Kerr's sign, and that is pain in the left shoulder. So if they might have pain in the left shoulder if the diaphragm was irritated or nicked, or if there's bleeding underneath it. So just let patients know that if they have pain in their left shoulder, they might want to talk with their doctor or check, have someone check their heart rate, blood pressure. It could be just irritation. But it might be something that if they're feeling a little weak or dizzy, might be something where they might want to check their blood pressure or their heart rate to see and talk with their doctor. So I think that's it. That was more than enough. That was really long on the liver. If you have not talked to pancreas already, we'll be doing pancreas, and we have gastric and intestinal as well. So I will see you at the next lecture.